Thank you very much, and it's a great privilege to be here. I'd like to congratulate Vanessa and the other organizers for a really magnificent meeting. I always feel very honored, but I also feel very challenged after Dr. Yakin's wonderful initial talk. I don't know what there is left to say, but I'll try to add something to it. Let me see if we can move. This is where I come from. This is the Mayo Clinic in Rochester, Minnesota, about 6,000 miles from here. My office is up near the top of the building on the left, which is where I see children with congenital disorders of glycosylation and many other disorders that affect the nervous system. This is something we do in America. It just says I do a lot of things, and you'll be pleased to know that any money from this goes to the Mayo Clinic, and the Mayo Clinic is very pleased about that too. So I'm going to begin just by reviewing the very first patient I saw with CDG, which was a little bit over 20 years ago now, and we'll talk about that. Then we're going to focus mainly on the neurological manifestations of PMM2 CDG, simply because it's the most common and because I think we can cover most of the ground there, and then summarize at the end. So this was a child I saw at 10.5 months because of delayed development. This child was born to a mother who had lupus during pregnancy. The child had been born by the breech and delivered by a lower segment cesarean section for that reason. And the important thing is that at birth, he was of normal weight and length and had a normal head circumference. However, he did have torticollis. His neck was turned to one side, and his testes had not descended, cryptorchidism. Now, by 10.5 months of age, the picture was different. Now, he had not grown, and so his weight was below the 5th percentile, his length was below the 5th percentile, and his head circumference was below the 5th percentile. And this is a very important finding that you've already heard about in the meeting, because by definition, if the circumference of a child's head is below the 5th percentile for age, in other words, 95% of children that age have a head circumference which is larger, that is abnormal, and it means that the brain has not been growing, because all other facts being equal, the size of the head is mainly determined by the growth of the brain. And of course, if the child were not growing in length and weight because of nutrition, the head would be spared. And I think all of you have seen pictures on television and in newspapers of children in Africa and other places who have been starving, and you can visualize their very thin bodies and limbs and what seems like a disproportionately large head. Because if it's only a nutritional problem, the brain will be spared. The brain is only about 3% of body weight, but it gets 20% of the blood flow. So it's very, very sensitive. It normally gets preference. So clearly, there's something primarily wrong in the brain in this situation. The child also had some other unusual features. His ears were low set, which means if you take a line through the eyes and project it, the tip of the ear is below that. That indicates there's been an abnormality in development. He had epicanthal folds, an extra fold in the inner aspect of the eye that you see in Down syndrome and some other disorders, and his tongue tended to protrude. His head was asymmetric with some prominence, so-called bossing at the front. He had inverted nipples and clinodactyly, which is curvature of the digits, particularly the 5th digits. And he also had areas where there was extra fat stored under the skin, so-called lipohypertrophy, and other areas where there was less fat than usual under the skin, which is referred to as lipoatrophy. And as we've already mentioned, he had undescended testicles, and his liver was enlarged. And when we examined this boy, he was very alert and cooperative. He was very hypotonic. Now, hypotonia is a word you hear often, and it means two things. You can refer to someone's posture or passive muscle tone, so that a child will lie, for example, with the legs spread apart instead of the usual position you see in a neonate. If you pick a child up, the child will tend to slip through your fingers, because muscle tone refers to the resting tension within muscles. If that resting tension is decreased, it can be either because there's a problem in central control from the brain and the spinal cord, or because there's a problem in what's called the motor unit, from the level of the anterior horn cells in the spinal cord, the peripheral nerve, the junction between the peripheral nerve and muscle, or the muscle itself. But in this case, because his development was generally delayed, because he still had relatively preserved strength, we know that this was central hypotonia. It was a manifestation of disease in the central nervous system. We also know the fact that his reflexes were preserved tells us that this is not a problem in the peripheral nerve reflex. It's a central problem that's giving him low muscle tone. He had a left esotropia. This means that the left eye was turned in. The term tropia refers to a misalignment of the visual axes. Normally, our central control mechanisms and the muscles that maintain the eyes in position keep them straight so they move together. But if there's a problem with the central coordination of this, one eye can turn in at times. If it's permanently turned in, it's called a tropia. If, on the other hand, it only turns in intermittently when a child is tired or ill, it's sometimes referred to as an esophoria. Now, this boy was unable to sit. He was just beginning to roll over at 10.5 months of age, which is later than it should be. It's typically by 6 months or so. And he was able to reach, but when he tried to reach, his reach was ataxic. And ataxia is a word you've heard often. I'd like to take a moment to explain that, because taxis comes from the Greek, and actually it referred to the way that soldiers would march in columns and hold their spears straight. And you can imagine if you have a group of soldiers marching together, if they're not keeping their spears straight, that could be a big problem for the soldier in front of them. So it's important. So taxis refers to the ability to perform movement in a coordinated fashion. So if you imagine, let's imagine I'm a conductor and I'm conducting the orchestra here, not necessarily very well, but you can see the movement of the limb here, and sometimes people refer to these sorts of limb movements as a kinetic melody. Now this is happening. Now I'm not very well coordinated. I'm not a dancer or a sculptor or anything else, but I can do this. And the reason I can do it is because my cerebellum is working, and I can close my eyes and do the same thing. So I don't need any visual feedback. So the question is, how do my muscles know when to contract and when to relax? And the reason is because there's a constant stream of signals that are coming from receptors in the muscles and the joints, which come through the spinal cord and predominantly into the cerebellum. And in the cerebellum, there's very complex circuitry. There are many types of cells: climbing cells, mossy fibers, ganglion cells, basket cells, stellate cells, all of which process these signals, and all of this information comes out through a single cell type called the Purkinje cell, or for our Czech members of the audience, Purkinje cell, the Purkinje cell, which contains the entire output of the cerebellum, which then feeds back, and it tells muscles when to contract and relax. What happens to this melody if the cerebellum isn't working? Well, you get what's called decomposition of movement. So when you try to reach and move smoothly, you see this. And you've all seen this in children who have, this is the origin of cerebellar tremor and so-called dysdiadochokinesis, which is a very big word which means decomposition of movement. Instead of making smooth movements, the movement breaks down into its component parts because the smoothing effect of the cerebellum has been lost. Now, the cerebellum is also important in maintaining your equilibrium and keeping you upright, again, because it's feeding back on all that information that's coming about position. So normally we can walk and talk because we need to coordinate the movements of the muscles of articulation, which includes the tongue, the muscles in the larynx, the muscles that are controlling the flow of air over the vocal cords. All of these things require an intact cerebellum. And if the cerebellum is not functioning, you can get a similar problem with speech. So instead of flowing, the speech can change so that it breaks down into its component parts. That's called scanning speech. And again, that's a loss of the normal flow, which occurs because the cerebellum is not functioning normally. So this is a very, very key aspect of congenital disorders of glycosylation, which this boy had. Now, when he was investigated, he had a variety of abnormalities, just the sort of things that first struck Dr. Yakin when he saw the young ladies who are guests here today. They had elevated levels of transaminases, enzymes that are present in the liver and muscle. The albumin level in the blood was low. Creatine kinase, which is a glycoprotein, it's an enzyme that's mainly present in muscle, was elevated. The cholesterol level and triglycerides, fats in the blood, were low. Thyroxine and thyroxine-binding globulin, which are involved in thyroid function, were low. Beta-lipoprotein was low. The liver, when it was examined under the microscope, had fat globules accumulating. And when imaging was done, the cerebellum was small, which we now know is a very characteristic finding in PMM2 CDG. Now, since that time, his development was slow. He developed progressive loss of muscle bulk or atrophy of the lower extremities. It was easy to obtain his reflexes when we first saw him, but he lost his reflexes, and this combination of loss of muscle bulk, weakness, and loss of reflexes implies that the peripheral nerves are now involved, and in fact we know that can happen with PMM2 CDG. He developed progressive ataxia of his trunk and limbs so that he required support to sit upright. Instead of having just one eye turned in, both eyes turned in, and he was not able to look out, so-called abduction failure. And when one looked in the back of his eye at the spot called the macula lutea, which means the yellow spot, which is where the cone cells are concentrated that confer most visual acuity, that spot had become pale, indicating that there was a loss of neurons. And his optic nerves also became pale for the same reason. And he began to experience epileptic seizures, which could be focal, in other words, seizures which would start in one part of the cortex and cause usually manifestations, typically jerking on one side, or they could be generalized, so both hemispheres of the brain and both sides of the body were simultaneously involved. Now, this is not his scan, but it's one very like his, and you've seen images like this before. Do we have a pointer I can use somewhere? Maybe I can use the, no, I can't use this. Well, I think you can see here, the image on your left is a vertical section through the head, and we got to, good. Thank you, Vanessa. So it doesn't project very well, but here, this is the brain stem. It's thinner than it should be, and the cerebellum should fill most of this cavity within the skull, which is called the posterior fossa. So this tells us something immediately when we look at this, because the posterior fossa is about normal size. Now, for it to have grown to normal size, the cerebellum should have been normal sized in the past. It implies that the cerebellum was larger and that it has shrunk. But it must have happened very early because he had these symptoms early in life, and we know that many children have a very small cerebellum at birth, implying that this process, which is targeting the cerebellum, is beginning very early in life before birth. When you look at a coronal section, a slice like this through the head, you see the cerebral hemispheres look normal, but the cerebellum here should be filling this space, and these little folds should be pressed so closely together that you can see no fluid between them, but instead they look almost like little palm fronds because they're thin. There's been loss of cells. And this appearance, where you see the cerebellum here looks brighter than the rest of the brain, has been described by some radiologists as very typical of CDG. And there are many other disorders that can cause the cerebellum to be small, particularly because the Purkinje cells are very vulnerable to many insults. But it seems that it's predominantly CDG where the cerebellum is small and bright. So that's a very important clue for us as physicians. This is another view showing you axial or horizontal sections. This is at the level of the eyes. Here are the cerebral hemispheres, and here's the upper part of the brainstem called the midbrain. And actually, this looks a bit like another condition. You can see, you can imagine that looks a little bit like a molar tooth. And there's a disorder called Joubert syndrome, which is caused by mutations in many, many genes, which can sometimes be confused with CDG, and the appearance can even overlap. Again, here, the cerebellum, you're seeing a lot of white here, which is cerebrospinal fluid. That's because the brainstem, the medulla in this case, and the cerebral hemispheres, the cerebellar hemispheres, are much smaller than usual. So what are the key features neurologically of PMM2 CDG? Well, as we've mentioned, there's low muscle tone, and initially this is what we call central hypotonia. Many, many different types of disorders of the central nervous system will be manifest in young children as low muscle tone. It doesn't mean they're weak. There are many babies you can pick up who are very floppy, who slip through your fingers, but if they're upset or excited, will give you a kick, and they're actually quite strong. So they don't have to be weak. Later on, they can have peripheral nerve involvement. The delay in development is very typical. Again, there are hundreds and hundreds of causes of this, and it's often, but not always, associated with what we now call intellectual disability, which used to be called mental retardation in the past. And I want to take a moment to explain that term because it's very important. It refers to a general impairment in cognitive abilities, so it goes across all domains of intellectual activity, which are arbitrarily defined as being having an intelligence quotient of 70 or less, provided you use an appropriate test. It has to be in the right language and culturally appropriate. But it also has to be accompanied by some impairment of activity. So, for example, if someone had a borderline intelligence quotient, but they were functioning well in daily life, then we wouldn't call that intellectual disability. It's only a disability if it impairs someone's activities and their life. And that's an important distinction between an impairment and a disability. An impairment only becomes a disability when it affects the ability to cope in everyday life, either to work at school, to perform activities of self-care at home, to obtain employment, and so on. We've already talked a lot about ataxia, and it's very important because it's a central symptom of this disorder, and it reflects impairment of the cerebellum. And we've mentioned the cerebellum, and there was some dispute early on when this disease was first recognized. Was the cerebellum hypoplastic? Had it just not developed normally, or was it an atrophic process? And I think now some people would say, well, it doesn't actually ever fully develop, so it's hypoplastic, it's never fully grown. But on the other hand, we have good evidence that it does lose volume, and I'll show you some examples in a moment. So to that extent, there is a progressive aspect to the disorder, although oftentimes the progression has occurred before the child is born. There are a number of so-called paroxysmal disturbances that are common. These are referred to as stroke-like episodes, which we'll discuss in more detail. And of course, children can have epileptic seizures. Now, I just want to take a moment to define epilepsy for you. Epilepsy has a very simple definition. It refers to recurrent, unprovoked seizures. So Professor Yakin was asked a question yesterday about a child having seizures with fever. Well, a seizure that occurs in the context of a fever is a provoked seizure. So that doesn't count. So you can have 50 seizures in the context of a fever, but that's not epilepsy. Those are febrile seizures, which are common, 5 to 6% of the population. Of course, some people who have a propensity to have seizures will have them unmasked by fever, and sometimes we only understand in retrospect. But that's an important thing to know. And of course, there are other diseases which can cause episodes that look like strokes, which may be associated with seizures. This particularly includes the mitochondrial cytopathies, and there are many of these disorders which are much more common than the congenital disorders of glycosylation. And of course, we've already mentioned febrile seizures. And the last thing I will mention again, which our patient had, was progressive neuropathy, involvement of the peripheral nerves. And involvement of the peripheral nerves can basically take two forms. We can have what's called an axonal neuropathy, where the nerve fibers themselves are affected, or where the coating around the nerve fibers, a substance called myelin, is damaged or is removed, a so-called demyelinating neuropathy. And demyelinating neuropathies, or demyelinating neuropathy, is predominantly what has been described in cases of CDG. I mentioned before that having a small cerebellum can have many causes. There are, as I mentioned, there are many mitochondrial disorders that can do this. One of them, perhaps the best known, and which can be confused with CDG, is called NARP. It's associated with a very specific mutation at position 8993 in the mitochondrial genome. There's a disorder called infantile neuroaxonal dystrophy, which can cause nystagmus, involuntary jerking of the eyes on looking to one side or the other, atrophy of the optic nerve, and ataxia. A disease in boys, a disease of copper metabolism called Menkes disease, and a variety of others, pontocerebellar hypoplasia, some unusual forms of spinocerebellar ataxia, which are diseases that usually present in adults but can present, and we've described this in young children. Ataxia telangiectasia, another progressive disorder of the cerebellum associated with immune deficiency, so it can be confused with CDG, but is actually a DNA repair disorder. And of course, most of the lysosomal storage diseases which involve the nervous system also involve the cerebellum, again, because the Purkinje cells are very vulnerable to many insults. In fact, the Purkinje cells are vulnerable to insults that people can inflict on them on a day-to-day basis. Now, it's possible, for example, that some people last night were drinking some very nice Spanish wine, and if they had more than 2 or 3 or 4 glasses, they may have been a little ataxic. And that's because the Purkinje cells are vulnerable to alcohol. So they're very vulnerable cells. So many people may not have just seen this in their children, they may have experienced it themselves. Here's an example of a child who had a normal cerebellum. This is at 9 months of age, and in the upper panel, the cerebellum is filling the posterior fossa. It looks normal. At 21 months of age, it doesn't project very well, but it's thinner. We can see more dark area from fluid here. So over that 12-month period of time, the cerebellum has shrunk. This was reported by some German colleagues a decade ago. And by 9 years of age, this looks just like the scan we saw originally in the child at birth. So clearly there has been an atrophic process. The cerebellum has shrunk because of the deficiency of PMM2. Now, I'm presenting some data here, and there are people in the audience who have published this, so they know this very well, but we have relatively little data about the long-term outcome of PMM2 CDG. So Dr. Barone, who's here, published this very nice study of 4 patients ranging from 14 to 26 years of age. They had a variety of manifestations, including microcephaly, a small head. They had a small brainstem and cerebellum. We sometimes use the term olivopontocerebellar atrophy. They were ataxic. They had dysmetria. That means if you're trying to reach a target, you either undershoot or overshoot the target, again, because the cerebellum is not functioning. We've already described scanning speech where words are broken up, another cerebellar sign. They had peripheral neuropathy. Their vision was impaired, and you're going to hear a talk later in this session about the eye in CDG, but the eye and the retina specifically is involved in this disease. Strabismus, which is another term for esotropia, where the eyes are not straight because of a central coordination problem in the brain, and pigmentary retinopathy. RP stands for retinitis pigmentosa, which occurs when clumps of pigment are found and which aggregate within the retina because of degeneration of cells there. And it's something that can be seen with the ophthalmoscope. These children were markedly delayed in their development, but they could walk with an aid, tended to develop communicative language after the 7th year of age. And again, their intelligence quotient, the measure of overall intellectual abilities, fell into the intellectually disabled range, less than 40 to 58. And there were some very specific impairments that Dr. Barone and her colleagues described, including problems with visual perceptual skills, visuospatial organization, eye-hand coordination, and verbal memory and language. And these involve many widespread parts of the brain and many neural circuits, again implying that this is a disorder which is affecting many, many parts of the nervous system. This was a case from one of my colleagues in Queensland, where I come from, in Australia, Jim McGill and his colleagues, who described a man who presented at 42 because of unsteady gait. Now, he clearly had problems in the first year of life. He was hypotonic. He had some mildly dysmorphic, in other words, unusual facial features. His development was delayed. He had recurrent vomiting and was not well nourished. And his ataxia actually began in childhood. When he was 22, it was thought he may have had one of the family of more than 3 dozen diseases called the spinocerebellar ataxias, which are usually dominant diseases inherited vertically through families. But later he had changes with hypogonadism. His bones became thin. His testicles atrophied. By the time he was 42, he was clearly intellectually disabled. He had ataxia, a bony deformity called pectus carinatum, which means pigeon chest, where the chest is keel-shaped. And he had a variety of abnormalities in blood tests, which again pointed very much to a congenital disorder of glycosylation. So again, we emphasize the great range of onset and the variable rate of progression of this disorder, which does not correlate well with the level of enzyme activity. There are clearly many complex pathways involved here. The deficiency of PMM2 is central, but it's not the only factor that determines the expression of the disease. Again, we heard from Dr. Perez Duenas, a lovely talk yesterday, and this was a nice study that she and her colleagues conducted on 8 Spanish patients, and they were able to describe neonates. 4 out of 8 of them had problems including cerebral hemorrhage, failure to thrive, so-called hydrops, where the body becomes swollen. Used to be common in the past because of Rh incompatibility. Now it's much more likely to be from an inborn error of metabolism, and 2 did not survive the neonatal period. 5 of the 8 patients had very severe cerebellar problems as well as intellectual disability, but only 1 had microcephaly, and that patient had a hemiparesis, weakness on one side at 7 years of age. Half of the patients developed pigmentary retinopathy with visual impairment, and 3 of the 8 were followed through to their 20s with a mean follow-up of 24 years. They lost the electroretinogram, so the retina was not functioning causing visual impairment. Their peripheral neuropathy became stable. Their intellectual disability was stable, and some were in sheltered employment, but none were able to walk unassisted. Interestingly, 1 out of the 8 patients had only gastrointestinal manifestations and no neurologic findings. So again, a very broad range of manifestations of this disorder. And you saw this picture, Dr. Perez Duenas showed this yesterday, but again, I show this to emphasize that neonatal hemorrhage can occur, and we have to understand that the nervous system can be primarily involved, or because of the other systemic problems, for example, the abnormalities of blood clotting, you can have these sort of manifestations, because for most of us, having our head pass through the birth canal is actually the most traumatic thing that's going to happen to our nervous system, thank goodness. So, stroke-like episodes. This was some work that was published by Philip Pearl and Donna Krasnovich in Washington, D.C. They described 3 children with PMM2 CDG who had stroke-like episodes, and they had imaging studies done which showed no evidence of ischemia or infarction. They did have electrographic seizures or intermittent epileptiform activity on the electroencephalogram, and all of these patients looked better when they were treated with anti-epileptic drugs. And one of these patients also did have some transient edema, some swelling of the brain in a focus. Now, this actually doesn't project too badly. For those of you who don't spend a lot of time looking at EEGs, this is normal-looking background activity, and EEG, I'll let you into a big secret in neurology, is not as complicated as it sounds. When we talk about the background activity, there are little markers to show 1-second intervals, and you count the number of waveforms per second, and that's the background activity, and you want to know the distribution. So each line here represents the difference in electrical potential between 2 points on the head. And there are certain patterns of montages that are very well established, so you can interpret this. So this is normal activity, this is abnormal activity, and this is what we call an electrographic seizure. So if you were looking at the child, you wouldn't see anything happening. But this electrical activity is occurring, and you see it spreads to become more widespread and eventually involves both sides of the brain, and then it abruptly stops. And so this was a brief electrographic seizure lasting 20 seconds. You wouldn't appreciate anything, but because the child was not able to recover fully, there was weakness on the one side of the body. So this is one cause of stroke-like episodes, and it's very important to diagnose this because you can treat this very effectively with anti-epileptic drugs and expect a full recovery. Now, here's another case from Dr. Ishikawa in Japan, describing a couple of children, one who had one had right-sided weakness at 5 years of age. There were clonic seizures, in other words, jerking of the right upper extremity, which was controlled with midazolam. The child did have abnormal coagulation studies. The platelet count, which should normally be more than 150, was only 37, which indicates either the platelets were consumed, forming a clot, or there could have been bleeding occurring. It took months to recover, and the patient had recurrent episodes of weakness which would last less than half a day but were not associated with any change on magnetic resonance imaging, suggesting that these two were likely seizures. However, there was a subsequent episode, and this shows the CT scan. Again, you can see the arrow here. This dark area here is not present on the other side. That indicates there's more water in the tissue, and that could be because there's transient swelling. At 4 days of age, it's a little more sharply demarcated, and this shows the view of the blood vessels. This is an MR angiogram from underneath, and what you can see here is here's the posterior cerebral on the right side. You're looking from underneath. This is back to front. On the right side, but here you don't see the complete course of the vessel because it's occluded. Here, when you look at the branches of the middle cerebral artery, there's an occlusion in this area as well. So this is, in fact, 2 small strokes that have occurred. So these are not just stroke-like episodes, these are strokes. And you can appreciate here at day 2 and day 20, this is called diffusion-weighted imaging. This shows a bright signal very soon after a stroke. After 20 days, it's disappeared. But with what's called flare imaging, you just see some brightness here. It's very apparent 20 days after the stroke, and the same with T2. So this shows the evolution of a stroke. So sometimes stroke-like episodes are, in fact, strokes, and that was the case here in this patient who also had seizures, because having a stroke can provoke seizures from the injured tissue around the site where the neurons have died. So this patient had a second stroke-like episode at nearly 7 years of age. This time he had left-sided what were called hemiclonic convulsions, so jerking on the whole left side, and followed by weakness. After that, he had seizures intermittently on that side, which were controlled with 2 drugs. It took 5 weeks to recover, but he had no more episodes than when he was treated with phenytoin. And this time, you see, he has an area of focal necrosis. So there's not a stroke, there's not an occlusion of a blood vessel, but there's a small area of tissue that has died, probably in this case because of intense electrical activity. So, some stroke-like episodes are partial or focal seizures, which can be followed by weakness. That's called a Todd paresis, after the Irish physician who described it about 150 years ago. In some cases, there can be swelling in one part of the brain. When that recovers, the weakness recovers. In other cases, there is a stroke, an ischemic infarction, because a blood vessel has been blocked, and those cells that are nourished by that blood vessel have died. In some cases, there's a little area of death of cells which doesn't correspond to a single blood vessel. All of these things can occur in one individual. So the important message is, if a child or an adult, more likely a child with PMM2 CDG, is having stroke-like episodes, we can't make assumptions. We have to investigate these children and determine if in fact they're having seizures, if they have swelling, or if they've had a stroke or necrosis, because the treatment will vary in each situation. So it's very important to investigate them and to understand that. I'm not going to spend a lot of time in this. This is 20 years old now. It's the staging system that Dr. Hagberg and his colleagues describe, which I think is still helpful to us. We're going to learn later in this session about a new staging system from Nijmegen. I'm very excited to learn about that. But again, this just really describes this early, very aggressive phase of the disease where children can have multiple organ failure and there may be problems with infection. About half the patients will acquire microcephaly, typically delayed, and there's quite high mortality. Children at this age can be very, very ill. In the second stage, most children are not able to walk, although we now know that there's a broader spectrum than was appreciated at that time. There can be some improvement. Some children can have involuntary movement, so-called choreoathetosis, these sorts of movements. The more proximal movements are called athetosis. The more rapid movements of the digits are referred to as chorea. Retinitis pigmentosa, we've mentioned, the stroke-like episodes, which tend to occur more in the second decade, but are not necessarily restricted to them. And they're often precipitated by an infection, and so it may seem at first as if they are febrile seizures, but febrile seizures are not accompanied by weakness. That's a red flag. And epilepsy can occur. And again, quite often at that time it was thought that no one had an IQ better than 60. We now know much better than that. And then the third stage they described is when patients will have the demyelinating neuropathy. The ataxia tends to be stable. And in the final stage, it seems that there's no further change or progression, that people enter a stable period. I want to say a little bit about neuropathology of the disorder. Again, this was a report from some of our Dutch colleagues. There's actually very little in the literature. There have been very few brains that have been examined from patients with these disorders. And they showed what was thought. This was a baby that died at 1 month of age. The child had a very small cerebellum. There was loss of the Purkinje cells and granular cells. Some of the Purkinje cells were in the wrong place. So that tells us something was wrong, because in brain development, beginning in the middle trimester, cells migrate from around the ventricles to take up their final position in the brain. If there's something wrong with the signaling, they can not go far enough, they can go too far. So this was telling us, again, it's more evidence that the impaired glycosylation was having its effect well before birth. And this just shows some photographs. And again, when you look at the brain from underneath, the cerebellum should be out to here. It's much smaller than usual, and the brain stem is much smaller. And you can appreciate it here. Now, if you've never looked at a brain stem at this age, this would mean nothing, but please trust me, this is very small, as is the cerebellum. And this just shows, again, I'm not going to spend a lot of time on the pathology, but again, there is a loss of cells here. The cerebellum here shows this thinning. You can see here, again, the folia are very thin and there's a loss of cells. And in fact, this shows in even more detail, and this is better because these upper panels show a normal cerebellum. This is stained with a substance called calbindin, which helps you pick out the Purkinje cells. And here are the Purkinje cells. This is the external granular layer, the molecular layer, the Purkinje cell layer, and the internal granular layer. This layer is present at birth in humans. These cells are still developing. They still have to migrate inwards. They haven't finished their development. So that's what a normal one looks like. This is stained with vimentin, so you can see the normal fibrous structure, the normal fibers within the molecular layer. Here is the patient with CDG or PMM2 CDG, and what you see is the Purkinje cells are almost all gone. Even at birth, there are very few Purkinje cells. There are still some cells in the external granular layer. The molecular layer looks very abnormal. When we look with this special staining here, these arrows show where there should be Purkinje cells sitting within these cells that are called basket cells. They've all gone. And then the axons of the few remaining Purkinje cells have these enlargements, which are called torpedoes. Or sometimes, when they're more globular, they're called axonal spheroids. And again, this suggests there's a problem with movement, with trafficking of molecules up and down the axon. So this is a very abnormal finding, and this is present in a newborn infant. Again, emphasizing that this process has begun long before birth. And Dr. Perez-Duenas showed this yesterday, again, showing these pronounced changes here with a control and here with loss of the external granular cell layer in this case. Again, just emphasizing the fact a very early onset process, which makes it very challenging to treat the neurologic aspects of PMM2. This just describes some of the findings, and I'm not going to spend a lot of time in this, except to indicate that all of these things suggest that there is impairment of the development of the myelin sheath and a failure to maintain this myelin sheath. And myelin around a nerve fiber acts like an insulator, an electrical wire. And so an electrical wire conducting electricity without insulation does so slowly. If you insulate it, it conducts impulses much more rapidly. And the same thing happens in humans. In the brain of a newborn infant, where there's very little myelin surrounding the nerve fibers, electrical impulses are conducted very slowly, and this is why a newborn infant with a normal brain can do very little, because the electrical signals are moving too slowly to integrate the activity of the nervous system. As a child lays down myelin with growth, they acquire skills because the electrical signals are moving more rapidly and the information can be integrated. The same thing's happening in the peripheral nerves. If they lose their myelin sheath, they conduct electricity very slowly, and also the nerve fibers lose some of their nutrition. And so there's double injury, and this is one of the reasons for the weakness and the loss of bulk of muscles and the loss of reflexes. And this just shows that the periphery is not spared in this disease. This is a muscle biopsy, and what you see here is unusual variation in fiber size. When you stain the muscle again, you don't see the sort of uniformity that's typical in muscle. So this variability indicates there's some impairment of the development of the muscle and perhaps its nerve supply. And when you look under the electron microscope, here's normal appearing muscle. It's very regular because the muscle fibers are comprised of actin and myosin, which slide in and out when muscle contracts and relaxes. But look what's happened here. These muscle fibers are in disarray. So the muscles themselves can be involved. It's not a major part of the disease, but again, it shows that glycosylation is important in all of these aspects of development, and it can be interfered with if it's not normal. So if we take an overview of the neurology of CDG, patients can primarily have what we refer to as a static encephalopathy. That is to say, beyond a certain age, there's no further change in the brain, although there may be some progressive aspect to the cerebellar disease early on, beginning before birth. Intellectual disability is common but not universal. The cerebellum is very much involved, but the cerebrum, the cerebral hemispheres are also involved because their involvement is required to explain the intellectual disability and seizures and some of the other findings that have been described. Peripheral nerve involvement is common but not universal. As we'll learn more about, pigmentary retinopathy can be a common finding. We've learned in the bigger picture of CDG that RFT CDG includes hearing loss very commonly, an unusual subtype, but it can occur in PMM2 CDG. We've heard about seizures, microcephaly, and the dysmorphic features, but again, secondary effects of the disease can impinge on the nervous system, so hemorrhage can occur. Thrombosis and clots can affect the function of the nervous system. Skeletal deformities can impinge and compress parts of the nervous system. Children may be more susceptible to infection, for example, meningitis or encephalitis. There can be episodes of coma related either to liver failure or that are unexplained, particularly in the first year of life. We've talked about stroke-like episodes, and seizures can occur, again, secondary to other systemic illness. Here's an example of a secondary effect. This is a child who had progressive cerebellar ataxia and shrinkage, atrophy of the cerebellum, but 11 years of age, the child had just been lifting and suddenly developed arm weakness, and when you look at the scan, you see a typical tiny cerebellum, but look here. Something is compressing the spinal cord at this level to a very remarkable degree, and when you look at a reconstruction here, you can see there's an abnormally developed odontoid process here of the second cervical vertebra, and there's soft tissue that is compressing the spinal cord to a tiny thread. So this sort of thing is very important to recognize. I wanted to show this to emphasize that although there are some aspects of neurological disease in CDG for which we don't have a specific therapy, there are others that can benefit. And so it's very important that we don't take anything for granted, but we investigate patients to make sure we understand the cause of their manifestations. This is eminently treatable, and if it's not treated, this child would have become, or had it not been treated, this child would have become quadriplegic. So, key features that I've mentioned. The neurological involvement in CDG begins well before birth, because glycosylation is very important in development of every tissue, particularly, it seems, in the nervous system. The expression of glycosylation changes with time, and so the expression of the disease changes over time as well. There are some patients who can have near-normal neurologic development. And of course, the concept of plasticity is important, and that means that in children who suffer an insult, their capacity for recovery is greater than an older person, and that's an important thing to bear in mind. I did want to make one final comment. Sometimes people talk about diseases being untreatable. I want to put it to you, there's no untreatable disease. There are diseases that are not curable. In fact, there's very little that we can cure in 2013. We can treat everybody, and there's a great deal we can do to help improve the lives of children and adults with congenital disorders of glycosylation. So I would urge you, please don't say these are untreatable diseases. They're all treatable, because treatment means we can help people, help improve the quality of their life, and I think that's terribly important. Of course, we want to have disease-modifying therapies, and we're going to hear about those later today. But I think that's a very important message I want to pass on. I want to thank the children and families I've had the privilege of working with CDG, CDG Family Network, and the other groups now, my colleagues at Mayo Clinic in particular, and I should have put Hud Fries in here because he's been a wonderful collaborator over many years now. And I've also had support from industry and from the National Institutes of Health. So I hope I haven't gone too much over time here. And I thank you for your attention. I don't know if we take questions now or later. I'll leave the chair to decide that. So thank you for your attention.